Hi, I'm Sophie from In the Mess, and today we're going to talk about hypokalemia. Potassium is important for the normal function of cells, particularly cardiac cells, so low levels of potassium can be very concerning, but not uncommon. Many patients in the hospital may be found to have mild to moderate hypokalemia and respond well to simple oral or IV correction. However, as levels continue to fall, patients can develop muscle weakness and tetany, which may include the respiratory muscles. Potassium levels may be low due to poor intake, high potassium losses, or potassium sequestration intracellularly. Why do I write these things? Poor potassium intake. This is usually seen in patients who are nil by mouth or malnourished. Additionally, in patients who have been starved or malnourished for prolonged periods of time, depletion of potassium, phosphate and magnesium can lead to refeeding syndrome on restarting intake, where the reintroduction of carbohydrates to the body stimulates insulin, which pushes these electrolytes into the cells, leading to a fall in serum levels. This causes cardiac arrhythmias, seizures, coma, and may result in death. Adequate replacement of phosphate, magnesium and potassium should be considered in patients who are at risk of being malnourished. There are numerous conditions that can cause high potassium losses, but they're mainly grouped into renal and GI losses. GI fluids are high in electrolytes, and excessive fluid loss from the GI tract can lead to hypokalemia as well as dehydration. In the kidney, use of diuretics can cause potassium wasting. There are a number of renal conditions such as Bartter syndrome, Gittelman syndrome and Cushing's disease which can cause potassium loss as part of their clinical picture. Ingestion of too much licorice can also lead to hypokalemia. Patients may also have hypokalemia due to excessive fluid losses from other conditions such as skin dysfunction or burns. Potassium sequestration. This may be seen as part of other illnesses. When the body becomes alkalotic, potassium is pushed intracellularly. There is also intracellular movement of potassium due to the use of insulin and glucose, such as a sliding scale, or activation of catecholamines, such as acute illness states or beta-2 agonist use in asthma. Management. As usual, assess your patient with a good history and examination and review the rest of their bloods for any clues that might give you the cause. In general, replacement of potassium with oral drugs such as Sandoz or KCl is usually enough to restore normal serum potassium levels. One important thing to remember is that the kidney requires adequate amounts of magnesium to be able to resorb potassium, and low magnesium levels can lead to failure to respond to potassium replacement therapies. But consider checking magnesium levels as well, as this can also be replaced. If your patient is significantly hypokalemic, a serum level of less than 2.5, or does not respond to oral replacement or they're unable to take it, they'll probably need IV potassium replacement. Potassium either comes pre-mixed in bags of IV fluids or it can be added later on. You should never give potassium faster than 10 millimoles per hour, as this can lead to fatal arrhythmias. Ensure the prescription of potassium is in appropriate volumes for your patient. Giving litres of IV fluid can quickly lead to fluid overload, so once the potassium is normal or your patient is able to take oral replacements, stop the IV fluids. Oral replacements usually taste pretty bad. It's like drinking seawater. And often patients who are potassium deficient are also low in things like phosphate and magnesium. Patients may be unwilling to take these medications without a good reason, so you need to have a chat with them and explain why they have to take them. To summarise, look for sources of potassium loss, consider whether your patient is at risk of refeeding, and never give IV potassium faster than 10 millimoles per hour. Don't forget to like and subscribe so you never miss a thing.